Okay, guys, welcome back to Individual Module 5.1, PowerPoint 4, and this is Lecture 2 to finish up this PowerPoint and the antepartum module prior to test number 2. So let's start off where we left off last time, and we're going to be talking about preterm labor. Preterm labor is labor that occurs after 20 weeks gestation, but before 36 weeks gestation. Signs and symptoms of preterm labor are abdominal cramping, a low backache, low abdominal pressure, bleeding or a change in discharge, the sensation of pushing down or pressure in the perineum, contractions, and sometimes intestinal cramping. So how do we manage preterm labor? The number one thing that we do is we hydrate these moms. So we make sure that they're drinking plenty of fluids, and if they're in the hospital, we probably will try to manage them with IV hydration. And the reason that we do this is because it prevents oxytocin release from the pituitary gland. Oxytocin is that chemical that makes our uterus contract. So we try to prevent that. These people will be placed on bed rest if it's a problem that persists, and we will also encourage them to be on pelvic rest or sex rest as well. We don't want anything irritating the uterus or causing oxytocin release. We want to identify any organisms and treat any infections if these people have a sexually transmitted disease. Different types of sexually transmitted diseases and infections can also irritate the uterus to contract. So if we can treat those infections, then likely we can prevent the preterm labor from occurring or manifesting into a preterm delivery. Tocolytic drugs are our first line of defense against preterm labor, past hydration. Tocolytics are things like terbutaline, and we talked about that drug in PowerPoint 3. Remember, this is a sub-Q injection that we give to moms to relax smooth muscle. Actually, terbutaline is a respiratory drug, and it's oftentimes given for asthma patients. If we can relax the smooth muscle, you got to remember what types of muscles in your body are smooth. Our airways are comprised of smooth muscles, so that should make sense to you why actually that is an asthmatic drug, because it will relax smooth muscles, open up the lung passages, and allow air to move more freely in those areas. Well, the uterus is also a smooth muscle. So if we give somebody terbutaline, then it will relax their uterus as well and prevent it from contracting. The thing with terbutaline is that it will jack up your heart rate. So we have to be very careful that we monitor these individuals really closely. If their heart rate is greater than 100, we will not give terbutaline. Procardia and Indocin are our second line drugs of choice against preterm labor. These are often PO medications. If we can control preterm labor initially with a tocolytic drug, and then we can get the preterm labor to stop, sometimes the MD will choose to put that patient on a second line tocolytic like Procardia or Indocin at home. So it'll be something that they take once they leave the hospital and once they go home to help prevent preterm labor from continuing to occur. Also, magnesium sulfate is another drug that we may use for preterm labor. This is in the most severe case whenever we cannot get tocolytics to work initially. If these people come back in with preterm labor and our terbutaline injections do not stop their contraction, our IV hydration does not stop their contraction, then the doctor may choose to these people on magnesium sulfate. Again, this would be an IV medication. All of the same nursing administration guidelines and concerns and considerations apply whenever we're giving it preterm, for preterm labor, as they do whenever we give it for preeclampsia. So again, we have to look for and make sure that our patient is not heading into a magnesium toxic state. Oftentimes we do end up with a loading dose and then a maintenance dose. We have to monitor reflexes very closely, blood pressure very closely, and again, same mechanism of action here works for preterm labor as it does for preeclampsia. We are relaxing smooth muscle. Uterus is a smooth muscle, so magnesium sulfate will relax that uterus and help it to stop contracting. Whenever we give it for preeclampsia, it relaxes the smooth muscle of our blood vessels, allowing them to dilate and decrease that blood pressure. If we have a patient who comes in preterm labor, we not only have to worry about the mom and her contractions, but we also want to prepare the fetus for delivery, because we may not be able to stop those contractions. So if we cannot stop them, we want to give the fetus the best chance possible of having a good outcome. So one way we do this is to give mom an IM injection of betamethasone. We give anywhere from 12 to 24 milligrams, and we give her an injection every 24 hours until she delivers. And what this does is it helps prepare the baby's lungs to mature so that whenever it's born, it has a better chance of having a good outcome, especially respiratory-wise. Here is another acronym to help you remember the different types of uterine relaxants or tocolytic drugs, and it stands for It's Not My Time. I standing for indomethacin or NSAIDs, N standing for nifedipine, which is a calcium channel blocker, M standing for magnesium sulfate, and T standing for terbutaline, an adrenergic agonist. Now, I want you guys to think about this nifedipine or this calcium channel blocker. What two things did we say go together? We say magnesium and calcium go together. Calcium helps our muscles to contract. If we block calcium from entering the muscles, then we can keep them from contracting. So I hope it makes sense to you why a calcium channel blocker would help relax the uterus. So whenever we are administering tocolytics, there are some considerations that we have to be aware of. We do not use this over more than a 48 to 72 hour period. This is not a long-term drug. This is a short-term fix, and if we can't fix it in the short term, we do not continue to use this medication. We give it sub-Q, and the dose that we give is 0.25 milligrams. It will induce tachycardia, it will cause hypotension, it will cause pulmonary edema, it will cause cardiac arrhythmias, and because of those things, it requires constant assessment and monitoring of the mom and the fetus whenever we administer this drug. Remember, if the mom has a heart rate of greater than 100, we will not administer this medication. We put these people on the pulse ox. We monitor their heart rate continuously whenever we give this drug, and we always have a baseline before we administer it. And on the flip side, from a fetal standpoint, in terms of assessing, we put the baby on the monitor and we monitor the fetal heart rate throughout the administration of this drug as well. So, what are our expected outcomes in terms of preterm labor? Well, hopefully we stop dilation. The bag of waters stays intact and does not rupture. The mom is compliant with drug therapy, especially if she goes home on some of those second-line tocolytic medications that we talked about. And we allow her to progress to a term gestation so that the baby and the mom have the best outcome possible. I believe I've said this before, but the number one cause of infant mortality in the U.S. is low birth weight babies. And there are so many different things that contribute to low birth weight infants, which is why it is very important to educate moms about the different things that potentially might cause low birth weight in babies. And it seems like such a simple thing, but it really is the number one predictor when it comes to infant mortality. So really important piece to pay attention to. Multiple pregnancies. We have a couple of different types of twins. Most of you guys probably know those as identical and fraternal, but let's talk about what that means from a pregnancy and an OB standpoint. So identical twins are also called monozygotic twins, or you'll hear them called monotwins in the OB world. And what this means is that this pregnancy has one placenta, one chorion, and two amnions. All right, so let's look at this. So this is our mono twin, okay? This one on the left. We have one placenta. We have one chorion. Where did my mouse go? One chorion. Okay, so right here is the chorion. And we have two amnions. So this is the amnion, right? The amniotic sac, basically, is what they're in. Mono twins are twins that have happened with one egg, okay? So one egg got two sperms, if that makes sense. And then we have dizygotic twins. These are your fraternal twins. These guys have two placentas, okay? You can see a placenta 1 on this side, placenta 2 on this side. They have two chorions. So here is one chorion, and here is the second chorion. And they have two amnions. So an amniotic sac here and an amniotic sac here. These guys are two egg twins. So we've had two eggs that have been implanted by two sperms. One sperm in one egg and one sperm in the other. All right, so I hope that makes this a little easier to understand with these pictures whenever we're talking about mono and di twins. Multiple pregnancies are at high risk for pregnancy-induced hypertension, preterm labor, anemia, congenital anomalies, and these people oftentimes have to have a C-section because one twin's turn one way and one twin's turn the other. So know what those high-risk categories are. Know the difference between your mono and di twins, and you should be good. Polyhydramnios. We talked about this a little bit in PowerPoint 2, I believe. Polyhydramnios is an overabundance of amniotic fluid. So our normal volume of amniotic fluid is anywhere from 500 to 1,000 milliliters, but whenever somebody has polyhydramnios, they end up with greater than 2,000 milliliters or greater than 2 liters of amniotic fluid. Possible causes that might cause this to occur are a fetal inability to swallow or a fetal overproduction of urine. Now, just like in normal, regular people who have diabetes, whenever they have frequent urination, the same thing happens to a baby if the mom is diabetic. So the baby might have an overproduction of urine, and remember we said that that's one way that we continually make amniotic fluid. If the baby has the inability to swallow, remember we also said that the baby drinks amniotic fluid and kind of recycles that. So there's two possible causes of what might happen in someone who has polyhydramnios. And the effects that this will have on a pregnancy is that it will cause preterm labor, and it will also cause malpresentation in the fetus. And what that means is that the baby will not basically present head down into the vaginal canal. So there will be a malpresentation or a bad presentation. It might be the shoulders trying to come out first, or a breech where the butt is trying to come out first. That's also considered a malpresentation. Oligohydramnios. This is the one where we have too little amniotic fluid, so less than 500 milliliters. Some possible causes of oligohydramnios include a fetal bladder or renal disorder, severe dehydration in mom, or a premature rupture of membranes without the mom noticing. So basically her membranes have ruptured, she's continued to leak fluid, and she doesn't really know that that's happening. And how does this affect the baby? Well, this baby will end up with weak fetal muscles at birth. Remember, amniotic fluid helps the babies to be able to move and develop appropriately. If a baby can't do this, then they're going to be born very flaccid and hypotonic. It will also have a failure of their lungs to develop appropriately. Remember, amniotic fluid also aids in the development of the fetal respiratory system. These people also, or these fetuses may also have distorted facial features. Specifically, this is called Potter syndrome. They have low-set ears, a beak-to-looking nose, prominent epicanthic folds, and downward slant to the eyes. So they almost look downsy, sort of. They may have pulmonary hypoplasia, which will cause respiratory failure, and their limbs may be deformed. Post-term pregnancy and post-dates. Let's talk about that for a little bit. Our normal length of gestation should be anywhere from 38 to 42 weeks. Anything greater than 42 weeks is considered post-term or post-date. And what happens when a placenta or a pregnancy becomes too old, then we get this senior citizen placenta. It's too old to work anymore. A placenta is only made to last for a certain amount of time. Anything beyond that certain amount of time will cause the placenta to start breaking down. It doesn't work as well. It becomes calcified. The oxygen level and the nutrient exchange between mom and baby are not what it should be. So we end up with issues there. We get a decreased tissue perfusion when the placenta gets too old. Babies also, when they are left in utero for too long, become macrosomic, meaning they become too large. Oligohydramnios is also an issue whenever we allow pregnancies to exist past 42 weeks. And meconium. Meconium is that first stool that babies pass, that dark, black, greenish looking, sticky stool. And what that consists of basically is amniotic fluid waste. And that's what causes the look of meconium. But sometimes when babies are stressed out or they've had a lack of oxygen for whatever reason, any kind of insult will cause the fetus to pass meconium in utero, and that is not a good sign. So typically, if you go past 42 weeks, you will see that baby have some type of meconium in the amniotic fluid. I have very rarely seen a pregnancy go past 40 or 41, 42 weeks where there was not meconium in the amniotic fluid. Pseudocyesis, that is the term for a false pregnancy. And yes, this really does happen. I have actually had a patient with pseudocyesis. It's really strange. But what happens with these people is they have all of the signs and symptoms of pregnancy. They get abdominal enlargement, but they have no fetal outline. So on an ultrasound, there's nothing there. They have positive pregnancy tests, believe it or not. Their breasts change just like as if they were pregnant. And these people really need some psychological counseling usually because they do think they're pregnant. Sometimes that's a good thing for them and sometimes it's not. But it's just a really strange thing that happens that I want you guys to know about. And that's basically all you have to know about it. I just want you to be familiar with the term and what it means. And that is the end of Individual Module 5.1, PowerPoint 4, and this is Lecture 2. Thank you guys for listening. Study hard for Test 2, and I hope you guys feel comfortable. Good luck.